Good morning. Uh, Thank you very much, Dr. Balraj, for giving me this opportunity to give you a lecture in front of you. My topic is on decoding demyelinating disorders. I am focusing more into ophthalmological point of view rather than going into too much of neurological point of view. Let's start with the case. A 17-year-old girl presented 4 years back with acute onset of loss of vision on the right side. No history of limb weakness, bladder or bowel disturbance. The regular blood investigations were normal. We done a serum, angiotensin converting enzyme, vitamin B12, D3. All the routine investigations for any acute loss of vision were done for the patient. The NMO antibody was positive. We have a package in Chennai called NMO MOG antibody package. We'll do that always, not to miss a MOG. So, and it works out very cost effective also if you do directly. And NMO was positive. Other autoimmune markers were negative. MRI of the orbit and optic nerves and brain showed short segment demyelination in the right optic nerve. So she had a 5 days standard treatment, 5-day course of intravenous methylprednisolone, 1 gram daily for 5 days. She recovered fully and subsequently started on azathioprine, 75 milligram daily. Usually I'll start with 50 morning and off at night, and only in difficult situation I'll go for the real 2 to 3 milligram per kilogram body weight. And with the regular CBC and LFT monitoring. This is also quite useful drug. Suppose patient is planning for pregnancy, especially many young women, we get neuromyelitis optica. They're going to start their life, and I have a collections of patients who are on azathioprine and had a baby. So this patient was on treatment, and it is a confirmed case of neuromyelitis optica because the NMO was positive. Then subsequently, it's not a Chennai patient. The patient came from north side, and she stopped azathioprine a few months back by itself. That is, she took for some years. Then she felt that I'm better. Why should I take medicine? She stopped it. Not came for follow-up also. Developed a sudden onset of total loss of vision on the left eye. So they panicked. They subsequently immediately came to Chennai. And there was no perception of light, and finger counting was not possible on the left side. So again, we done all the investigation. We have to make sure, even though we know this NMO, that we done all the investigations. Because quite a few years back it was done. Everything was normal. Because we do that to make sure there is no other autoimmune disease. Because we know there are times it is not a pure NMO, it is a NMO spectrum disorder. The patient can have other autoimmune disorders. So NMO antibody was positive and other autoimmune markers were negative. MRI of the optic nerve, orbit and brain showed a long segment demyelination of the left optic nerve. I think the radiologist who spoke before, it showed the long segment demyelination is classical of NMO. Even that long segment demyelination of the optic nerve, this time compared to last time it was a short segment, this time it's a very long segment demyelination of optic nerve. She was given 5-day course of intravenous methylprednisolone and no improvement in the vision was noted. So last time she responded, this time there was no response. So it's a very aggressive relapse. So patient came to the clinic again, said that nothing happened to me. I'm totally no improvement at all. You can see there is a long segment of optic nerve demyelination. So in this kind of situations, or if you suspect that the patient is not going to improve the steroid, we give a rituximab. And I was telling in the morning also, we were discussing, and that we buy sometimes directly that it costs around 40,000 plus. In difficult situation, buy at concession and come around 10,000. So, but it has to be given an ICU setup, or at least to be in a monitoring setup. So what we do is we give 1 ml of Avil injection intramuscular, then 125 milligram methylprednisolone intravenous in 100 ml of saline, which run over 30 minutes. Then 500 milligram of IV rituximab as an infusion over 5 to 6 hours. So 125 milligram in 100 ml saline, 30 minutes, 1 ml Avil IM, then 500 milligram of rituximab in 500 ml of saline. And first 1 hour we'll give 50 ml, then the remaining 450 ml will give over 5 to 6 hours time. So the patient do extremely well to make sure that we don't get any allergic reactions or anything. Usually they do well, but only in some such, so if it happens, then we should know how to handle it rather than just giving without monitoring. So she recovered significantly in a week day. The patient done extremely well. So she was started again on azathioprine and daily on a long-term basis. She's doing well now, and there were no new symptoms in the vision or in the neurological system. So this is the overlap area that the patients with optic neuritis, they go to the ophthalmologist, then they come to the neurologist for further workup. It's a teamwork. There are times that patient can have both symptoms, both optic neuritis and myelitis. Then that situation, patient come to the neurologist directly. And every time I still get opinion from the ophthalmologist to make sure that the patient have a good view, because it's not purely the patient say that I'm feeling better. We have to assess all the system in optic now, and whether color vision, everything, patient doing well. Sometimes patients say that I don't have depth of perception, I could not able to see colors. We should not find fault in the later that we are not assessed ophthalmologically. It's better, it's basically teamwork. So it's important to image optic nerves in patients with optic neuritis to neuromyelitis optica. Not only NMO, any optic neuritis, we have to image the optic nerve, because it tells us that whether it's NMO optic neuritis, there are ways we can differentiate NMO optic neuritis and MOG optic neuritis, multiple sclerosis optic neuritis. So a lot of findings gives a clue that what kind of optic neuritis we're handling. If there is a long segment of demyelination in the optic nerve, rituximab may be a choice in difficult situation. It's a quite effective drug. And I think many autoimmune disorders, even rheumatologists stop using immunoglobulin, quite expensive. IVIG cost a course around 4 lakhs to 5 lakhs. And it is not a stronger drug like rituximab. There was a discussion about natalizumab in the past, in the previous discussion. If you suspect natalizumab, NMO, you should not give natalizumab. Natalizumab can aggravate neuromyelitis optica. So rituximab may be a choice in difficult situation. So we should, whenever we see the spots, the white spots in the brain, we should be very careful. You know, the last time I think the speaker showed so many slides. Always keep in mind all white matter shadows are not just a demyelination. It's demyelination general entity. I had a patient's multiple sclerosis, the neuromyelitis optica, MOG antibody disease. Recently, I saw a patient who was treated as a multiple sclerosis for years together. Subsequently, the patient told, I'm not doing anything well at all. I'm going down. Then it was turned to be cadacil. So even cadacil, any white matter disease shadow, that we have to be very thorough to make sure that we are not missing any sarcoid, cadacil, or small vessel disease of the brain, CNS lymphoma, so many white matter. All white matter shadows are not demyelination. But the only thing is my MS shadow and neuromyelitis optica shadow and MOG shadow. The shadow can give a clue that what kind of demyelination we're handling. Plus, we have to look for the antibodies and oligoclonal bands and visual neurophysiology. So many things. We have to take a conglomeration of investigations, because in the medical legal era, we can't afford to just casually treat a long-term neurological disease without a proper conclusion. So you can see that there's a quite long, thick, fluffy shadows. And the second one on the spinal cord, you can see a long segment demyelination. That gives a clue that we are handling it, because in usually MS shadows are very bitten pieces and not very long segment. So NMO is a multifocal inflammatory demyelinating disorder of the central nervous system that preferentially affects the optic nerves and spinal cord. Isolated optic neuritis is a common presenting sign in the NMO, as well as in the more common demyelinating disorder, multiple sclerosis. Because the patient, when they come to us with optic neuritis, the visual complaint, and usually it is only purely visual, they go to the ophthalmologist. Very rarely they come to the neurologist directly. And we also don't encourage, we always ask the ophthalmologist to see, and we do investigation along with them. Most of the MS patients occur significant visual acuity following optic neuritis. NMO patients often manifest severe visual loss. So the first question they ask is, what is wrong with me, and what is going to be the prognosis? Am I going to recover fully? So we should be very, very careful before talking about the visual prognosis, what kind of optic neuritis we are handling. So the incidence of neuromyelitis optic disorder is a monophasic illness. 1 to 10% of patients, men and women, are equally affected. One retrospective study of patients found that Asian, Afro-American, and Afro-European patients seropositive for acoparin antibody at a younger mean age of onset and a higher prevalence of brain and brainstem involvement than Caucasian patients. So you should be very careful. I saw few years back, one of the senior clinician by himself is an ophthalmologist, and he came with just a loss of consciousness. And the MRI showed that the demyelination starting from the brainstem up to the dorsal spinal cord. Such a severe neuromyelitis patient who had I positive for NMO antibody. So the first episode itself is quite bad enough. So they're all triggered by the virus, and they're all autoimmune phenomenon. But how our body reacts to the insult is very important. Hallmark feature is acute attacks of bilateral or rapidly sequential optic neuritis, leading to severe visual loss or transverse myelitis with a typically relapsing course. So if you take the optic neuritis and neuromyelitis optica, it's unilateral, sequential optic neuritis in rapid succession, or bilateral simultaneous optic neuritis. It can be unilateral, it can be bilateral. So the disease pattern is a relapsing course in 90%. So they do relapse. That's why the first patient I thought that she's normal, not came for follow-up, got another bad optic. She's lucky enough to get back the vision. In some patients, optic neuritis and myelitis occur concurrently. In that situation, we receive the patient first. Pure optic neuritis, more than 90% go to the ophthalmologist. And the patient will have myelitis and neuritis, they come to the neurology OP directly. In others, clinical episodes are separated by a variable period of time. Patients with cerebral presentations can have recurrent brain attacks without involvement of the optic nerves or spinal cord. I still remember a young man who had a brainstem lesion. He got a recurrence in the brainstem. I have collections. I think I have 3 or 4 young men who had the similar problem. One of the person that whenever you laugh with the lesion in the brainstem, active brain lesion, he is just dropped down. You go for a drop attack. And subsequently, he was treated and is normal. Then he got married. And then they want to have a children. And he was on mycophenolate mofetil. So mycophenolate mofetil can affect the sperm count as per the previous studies. So he came back to me. These fellows, as Dr. Ambika was telling in the morning, they do all literature search and come and sit in the clinic and teach you neurology, whatever field you are practicing. So Dr. Pazhani, I found that this drug will be excreted in the sperm. So do you think my child will get some problem if my wife conceive? So then I told that, okay, we'll go to azathioprine. Then I put him on azathioprine. He got pancreatitis. He got admitted in the hospital. Then subsequently managed to recover from the pancreatitis. He come back and told that, what can I do? Then luckily I was searching the literature here and there. I found that this study is not having significant relevance. Mycophenolate can be safely given during if they're planning for a baby. So the mycophenolate for men. See, we are talking about always the teratogenic effect on women. Now, a lot of drugs people are talking about teratogenic effect through men. And especially the sodium valproate. We use epilepsy drug. A lot of literature on that. Be careful while using for a potential men. They're going to have a baby. So this the other side problem also started slowly in every field. So this man subsequently the mycophenolate, because I got a literature, I started him and they had a baby is fine. I'm safe. So you have to be very careful with a lot of these things. Some questions we don't have answer. They come with the literature and ask you, you have to go and read. I tell I'll read and come to you tomorrow. Then he come back tomorrow after I read it, then we discuss, sort it out. So so if you go to some difference of MOG compared to the neuromyelitis optica disorder, the more likely to involve optic nerve compared to the spinal cord, more likely present with simultaneous optic neuritis. We should not get cheated. This simultaneous unilateral. Always take everything together. Because the books are written based on what they see. I always tell my professor when I was in England, Professor, this point is not in your book. He told very nice, Dr. Pazhani Ranganathan. I will include in my next chapter. So, okay. So you may be observing something which is not in the textbook. So don't get cheated by this unilateral, bilateral. Sometimes you have to go through everything. More likely to have monophasic or to have few relapses. Less likely as with other autoimmune disorders. More brainstem and cerebellar lesions and fewer supratentorial lesions. Spinal cord lesions mainly occur in the lower portion of the spinal cord. This be careful. I had collections of patients who had a conus medullaris inflammation. They have perineal numbness, they have sphincter disturbance, and they come to you, then you do see there is a demyelination there. I had only one patient who had both optic neuritis and this conus medullaris inflammation, and the MOG was positive. So if you see a lower spinal cord lesion, and always keep in mind it can be a MOG. Optical OCT, the neuromyelitis, the optical spectrum disorder, the greater retinal nerve fiber layer thinning, and there is a severe axonal insult. Microcystic macular edema of the inner nuclear layer appears to be common among patients with neuromyelitis optica spectrum disorder. So there is entity called clinically isolated syndrome. There are times people do MRI for no reason, like you do a MRIs for headache, and sometimes people say giddiness, vertigo. So we do, because you missed something, then they come and say that you missed the diagnosis and all the problem. So people do investigation. Then you find this white matter shadow here and there. So then they entity called clinically isolated syndrome. So defined as a clinical demyelinating event that is isolated in the time and mostly as the initial attack of multiple sclerosis. But there are times people see only clinical radiologically isolated syndrome. What I'm telling is clinically isolated. You see radiological white matter shadow, no clinical symptom for this patient. They may be, I have one patient who is 25 years having the shadow, and patient is fine. And the patient visited all the neurologists everywhere, and asking for some treatment. She's scared she may get some disease later. Nothing happened over past 25 years. Patients with clinical isolated syndrome may present with a wide variety of symptoms, including sensory, pyramidal tract, brainstem symptoms, cerebellar involvement, optic neuritis, and transverse myelitis. So CAS optic neuritis may be the initial presentation in 20% of MS patients, and optic neuritis presentation may occur during the course of the disease in 50% of patient multiple sclerosis. So the problem is the patient come in the initial stage and you start the disease modifying treatment, and most of these patients do well. Most of the time I see people who come late, or they not had any disease modifying therapy, our initial presentation itself is very severe. Those are the people who go for a chronic course or they go for disability. All the patients under me, many young women, like they're studying in the US, doing some post-graduation course, and the people working in some big companies. We don't need to go for very toxic, expensive drugs. The regular available drugs are quite good enough. And we used to give glataxone, glatramine acetate, for women with potential to have a baby. And suddenly the company felt it is not giving an adequate income. So they stopped giving to Indians. So I had a patient, after 3 months, they had a glataxone, and medicine was stopped. I don't know what to do. Then the lady was sitting in front of me. Then the company told, no, sir, we are not going to commit with this drug, and it's not profitable. Then I was thinking, in the meantime, that they told beta ferron may or may not be safe. Again, I went and searched the literature. I found the paper, latest paper, that it can be given during pregnancy. So I started on beta ferron, and she subsequently delivered, baby is very fine. So this is the problem, that suddenly what we see in the literature, and you are looking for the drug which is not available, and what is available, you have to search and make sure that you have to help. The patient says, I don't know where to go. I'll sit here, you sort out my problem. I am 3 months pregnant. You told that you are going to give the drug is not available. Do something to me. So optic neuritis treatment trial studied the visual function outcome of optic neuritis patients over 15 years, and visual acuity, contrast sensitivity, and visual field parameters were evaluated. Among the patients with acute unilateral optic neuritis, 79% showed improvement by 3 weeks. That's the beauty of MS. They have some problem. By the time they reach you, they become better. But we should not leave them, because subsequently again they come back with another optic neuritis or some cerebellar problem or some other problem. So that is a warning sign. We should immediately take them for investigation. It is like transient ischemic attack. Many times people with TIA come, you put aspirin stand. It may be a warning sign of a bad stroke going to come, impending stroke. So these are all signs which we should take seriously and work them up further to make sure we are not going to get there. We are going to stop the volcano going to erupt later. 93% improved by 5 weeks. Rarely visual recovery was not complete, and some patients failed to recover. That is 5 to 10. They also have a small proportion of people who don't do that well. So we don't know which group these patients belong to. We should start immediately whatever need to be done. It was suggested that long-term visual outcome was favorable for the majority of patients, even when MS was present. Even if they are MS, already existing MS residual symptom, they get the optic neuritis. The optic neuritis component of the MS do better compared to the remaining part of the MS. Painless vision loss may also be seen in 8% of patients with typical optic neuritis. You know, the thing, anybody has, they say painful optic neuritis, but they can be painless optic neuritis. So don't depend on one clinical sign to differentiate. This is not this is not this kind of thing. Always take conglomeration of symptoms and signs and technology together to come to a conclusion. Then write a book on that or paper on that, because always there is exception. Severe visual loss with no light perception, progression of vision problems, or persistence of pain over 2 weeks, and lack of recovery even after a couple of weeks after the initial presentation are all unexpected features in multiple sclerosis. Bilateral, simultaneous, or sequential optic neuritis is also not expected in common idiopathic optic neuritis, but may be absolutely NMO. That we discussed. NMO is a more severe form of optic neuritis. Recent evidence has shown that RFNL thickness reflects axonal degeneration atrophy. OCT finding seems to be related to visual impairment as well as disease progression. So I think this is the place that people come to as a teamwork, because we don't do OCT. We don't know what is. If you start learning everything in every field, then you'll be confused. You can't do your own job. I stopped doing this. I used to do when I was young. I have energy to go here and there, echocardiogram, ECG, that, this and all. And then one day I found that this all, we are trying to get into other people's field, and we are not focusing it our own field. I never do that. I stopped doing that. Always you have expertise in your hand, and ask their opinion on this. Another time people say, why don't you buy a OCT, keep in your clinic and start doing OCT? Then I have to go and learn OCT. It's total, that's not my area of expertise. So always better that you use the area of expertise. Anytime medicine is teamwork, it makes your life more interesting rather than just to start doing everything by yourself. Follow up with the OCT and assessing RF fundamental thickness may predict visual recovery after an optic neuritis relapse, and lower RNFL values may be correlated with the impaired visual function. OCT may be a useful marker for axonal function of optic nerves after optic neuritis. There are a lot of papers on MS on about this OCT, predicting prognosis, predicting how the pattern of MS is going to be. It is a window of brain. It tells a lot of information. The ocular system is a window of the brain. Recently, studies utilizing B-mode transorbital ultrasonography for optic neuritis have also been reported. Many papers are there. I think the radiologist expert told about that. Application of transorbital sonography might reveal a thickening of the retroorbital portion of the optic nerve during an optic neuritis relapse, reflecting inflammation. Suppose we don't know whether it is a old optic neuritis or something active inflammation is going on. This may give a clue to you. And because sometimes we think, okay, it is a burnt out optic, now we leave it. And the whatever remaining also will burn out later. So that is better to know that are we handling a burnt out inflammation or ongoing burning of so-called the active inflammation. The transorbital sonography seems to be sensitive, highly accessible, and user-friendly technique. Further long-term studies are needed for the application of this method. We need a lot of study, there's a lot of technology coming. We need to go on study and we need to refine it. So Mealy et al. Showed that NMO lesions were longitudinally extensive, measuring at least 17.6 millimeter length, and would involve at least 3 optic nerve segments, like 3 optic. You take the spinal cord, 3 vertebral length demyelination gives a clue that it's a NMO demyelination. Like that, there's also 3 segment of optic nerve demyelination gives a clue it is a NMO demyelination. MS lesions are commonly focal in one optic nerve segment, localized anteriorly. These findings seem to be specific, 76.9%, and sensitive in 80.8% for NMO. OCT is a usual method for showing axonal degeneration of optic nerve fibers and may help in distinguishing MS and NMO. Recent studies show that optic neuritis and neuromyelitis optica typically would result in severe RNFL, which I was telling before also, ganglion cell layer thinning, microcystic edema, macular edema, all those things. The silent optic nerve lesions and RNFL thinning may occur in MS, but it is rare in neuromyelitis optica. That's why if the patient don't have visual symptoms also in multiple sclerosis, if you do a OCT, it may tell that what is happening in the neuronal level. Atypical optic neuritis in MOG antibody disease and neuromyelitis optica spectrum disorder are less likely to have a spontaneous resolution. So MS, as I was telling before the patient come to the clinic, then by the time the optic nerve become better, we should not leave that. We have to look for MS and treat the MS so that it will reduce all the relapses, including the optic nerve. But it is not that like that in MOG or neuromyelitis optica spectrum disorder, because they don't go for a spontaneous resolution. We have to go and interfere. MOG optic neuritis may offer a better visual outcome compared to neuromyelitis. Both are bad enough. One is more bad than the other one. And we have to go for a proper treatment to prevent further fatigue. Vision is so important. And we had, me and Dr. Ambika had seen so many patients together, how these patients are all college-going girls and studying engineering. I had still one patient, I think you remember that she finished B with one eye, and she got married, and now she's working as some senior project manager in another company. I think almost 10, 15 years story. Identification of optic neuritis characteristic in multiple sclerosis, MOG antibody disease, neuromyelitis optica spectrum disorder is important as a visual prognosis, and treatment approach varies, because every time the patient comes to us, I don't think they leave, okay, we have NMO disorder, I'm going to give treatment. Do you think they'll go away with your clinic with that answer? They will sit and talk to you for another 30 minutes and ask you some 30 questions, which you don't answer for another 15 questions. You have to go and read and come back tomorrow. Because I'm reading constantly, because now I know most of the questions what they're going to ask. I'm mentally prepared to give the answer. They'll ask, what is my visual prognosis? What you are going to do? What are the other alternative methods of treatment? I remember that one patient got retired and came with some money, and he got NMO. He got visual optic neuritis, and then he gone for IVIG, 5 lakhs gone. Then he gone for plasma exchange, all money gone. Then he came in a wheelchair. Then they told that I don't know what to do. 3 months of onset of illness. We don't have money also. Then luckily the rituximab we gave and he totally recovered. Now he's cutting air for his grandson. So this drug can even work after 3 months. Wonderful drug, and not that expensive like other treatments. So sometimes I think better to use this directly in a difficult situation rather than waiting to others track them go for it. MOG optic neuritis was found to be 10% among non-infectious optic neuritis, a case in Japan, and it stands for 13% of recurrent optic neuritis. Recognition of this disease is important as patients are commonly presented with severe optic neuritis with frequent relapse, which require different therapeutic approach. Patients in one series are all young females with the disease onset occurring between 7 to 37 years old. So we see in pediatric, and we always have issue that we are all, most of us are not pediatric consultant. Those who practice the expertise are, most of them are adult people, and we sometimes see a lot of these young people. Nowadays, I have patients of young pediatric population, multiple sclerosis, with the ADEM, with MOG, everything, then where they will go, they have to look for, come to the specialist. There are only few pediatric experts are available. And more or less that the training we do in our setup, that we also trying to handle some of the pediatric issues also, because there is no other option. This disease typically affects younger patients than neuromyelitis optica spectrum disorder, with median age of onset in the early to mid-30s and more balanced female to male ratio. So bilateral simultaneous optic neuritis attack, which was reported to occur in 51% of, so in MOG, you see very often that bilateral, and NMO it can be bilateral, MS usually unilateral, can be occasionally. MOG and disease patients may develop myelitis, encephalitis, and seizures. It has been reported that 30% of MOG patients with recurrent optic neuritis may not show any other neurological symptom. They'll be going only to the ophthalmology OP. They'll be sitting in front of the ophthalmologist. And obviously, most of the experts now, they know that it is the teamwork, and they always, I get so many patients from them. I send back to them with my neurological opinion, because the patient don't have any other neurological manifestations apart from the optic neuritis. So they need more of their expertise on a long term. And only if anything happens, they will, then also treatment going to be the same. But they need a neurological opinion if it happens. In MOG, optic nerve enhancement in MRI tends to be longitudinally extensive with perineural enhancement, usually sparing the chiasm and optic tract. So the chiasm and optic tract is spared in MOG optic neuritis. So that is also important. Whenever we're seeing that, whether it's anterior inflammation or post-inflammation, or small bits of inflammation, whether optic tract and chiasm is spared or involved, all those give you a clue that what kind of disease, antibody, clinical presentation, age and gender, so many things. So one report of patients with severe attacks found that initial treatment with IV steroid plus early therapeutic plasma exchange was improved the outcomes. But I was telling that there are times it doesn't work, then we go for the other. IV immunoglobulin has not been specifically evaluated for acute attacks of neuromyelitis optica and rarely used in this setting. You give 4 lakhs worth of drug, it doesn't work. So the people, I think, go for steroid, IV methylprednisolone. But the only thing, IV methylprednisolone, whenever I always write in the prescription, if you have any hip pain, kindly report. Take one X-ray of the hip after some time. There are times you see a avascular necrosis after some time, especially after COVID. I saw quite a lot of people who had a steroid had a avascular necrosis. They come to me with the hip pain, back pain. They thought there's a disc prolapse. Then you do a scan of the hip. They found the hip was collapsed. So it's better to document and make sure that we don't miss any hip issues later. So rituximab is, you know about the pharmacology of the molecule. It reduce the analyzed relapse rate. And there are a lot of study and Japan study, Western study, many studies are there. So there are systematic reviews and many papers are available. And whatever I told about, they write so many things, leukopenia, but most of the time, all of these patients, they're all doing extremely well. And only thing you have to have a count, make sure they don't get any infection. And then usually they present, if they still treat, they become better. And make sure what accounts are assessed and all those things. But anyway, you are going to give a single shot, not like other oncology where they give periodical. These drugs are used for other specialty also. So thank you very much for listening to me.